Hey everyone, good to see you all again. Thanks for joining us for today's episode of Overfilled the podcast. Jason and Brooke here. Jamie is busy with patients today. Today we're going to talk a little bit about fine-tuning our ability to align those haptics to the ocular surface when some lumps and bumps are involved. Jason, good to see you again.
You too.
As you all know,
been that long, thankfully, but
it hasn't been that long. It's only been like a week, so
Yep.
That's good. So as many of you know, we like to start off our podcast with what has overfilled us in the last week, what's brought us joy, both inside and outside the office. So Jason, why don't you share with us how it's going?
Yeah. So of course, this week we were both in San Diego for the ICSC conference, which we go to pretty much every year and you're so involved with. And so I'll just say overfilling me there, got to spend quite a bit of time talking to good friends, and in particular, someone I haven't seen in quite a while, Tom Arnold, was there, and I got a nice probably 20, 30 minutes just to sit and catch up with Tom. And so, that meeting is always overfilling just because you see people that you've spent a lot of time with in the past and you haven't seen them in a year or two, maybe, and just an opportunity to catch up and reconnect. And I don't know, it's one of those meetings that it's a little bit like GSLS, but even kind of in some ways better because it's even smaller and everybody is scleral. And so it's like literally everybody, they either know them or you should know them or they want to know you. And so it's a good time and some good dinners and got to hang out with some residents. And so just a great time. So that would be my overfilled, is getting to have those few days at ICSC. How about you?
Yeah, I agree. ICSC was great. Many of you know that I'm one of the chairs, so put a lot of time and effort into getting the meeting organized every year, inviting and introducing topics to the speakers and things like that. So in a way, I'm overfilled that it's done. I think it's okay to say that. Anytime that you get over the hump on a big project, it always feels good to kind of get it behind you and start to recharge for the next year. So that's where I'm at. And I also got to spend some time with my Vance Thompson Vision Work family after the ICSC meeting. We had a leadership retreat. And so I scooted out of ICSC rather quickly and got to Nebraska, where our leadership team was meeting at a nice golf resort. So got to spend some time with them too, which was great. And then to top it all off, today we have a work pickleball event, hence Nike t-shirt.
Right.
Ready to go and gonna go over there, kick some butt, stay out of the kitchen kind of stuff. So
there you go.
Do that this afternoon.
Yeah, don't foul.
Fun time with the work friends.
Sounds like fun.
Yeah.
So you have some cases,
I just have a
lumps to deal with cases.
Yeah, I just took a couple images of a patient that I saw recently that, while it's not all that complicated, it is a good reminder, especially for patients who maybe not patients, fitters that are still learning how to navigate, pinguecula or conjunctival cysts or any sort of focal elevation. Sometimes they even feel like a muscle insertion or something, like the sclera just has kind of a rounded shape to it, can benefit from adding in a microvault. Microvault certainly is a term specific to the Zen lens, but I know that there are other lenses that have, a similar a similar part to it, even though Zen was first. Let's just say
Yes.
To throw that out there. But anyway, so just wanted to show some pictures and kind of talk through it, and hopefully everybody can take away a pearl or two on understanding these fittings. So looking at this, the gentleman was commenting about having some fogging, and as you can see, there's a little bit of fluorescein exchange, superior temporal and nasal there. And initially when I put this lens on under white light, you don't really notice much misalignment or anything like that. But when I see a pattern of fluorescein exchange, above and then aligned and then below, it makes me wonder why there's that kind of C-shaped fluorescein exchange noted nasally. And so it made me wonder, like, am I lifting off? Is the lens landing on that area of alignment allowing for fluorescein to, creep above and below. So if you go to the white image next, the white light, it doesn't look obvious there. The pinguecula is not. Sometimes most of the time, pingueculas are kind of like fleshy, callousy looking. They just have a different texture than the conjunctiva. Where here, it's not so obvious that there's actually or probably an elevation under this lens. The pinguecula is also a little closer to the limbus, so it's basically fully covered by the haptic of the lens. And that's another way that I think pinguecula can kind of hide underneath the lensing zone. And so we did end up adding in a microvault into this case here, and just measured it. And we'll talk a little bit about how we decide on the size of the pinguecula that we're gonna fit. And anyway, so that's kind of my tip here, is that sometimes those focal elevations, this could be a conj cyst, it could be just a milder pinguecula as far as appearance goes. And so again, it's easy to hide under the haptic.
Yeah, and it doesn't look super blanched, which sometimes, they look super white because of the compression. It doesn't look super blanched. It looks maybe a little. But what's interesting too, though, is above and below in those corridors of fluorescein, you can kind of see that yellowing above and below. It almost looks more inflamed there. And I wonder if that excess space again is allowing for the blood vessels to carry more, so that that's why that area is less impressive. Maybe it's drawn.
It's like getting diverted almost.
Yeah. And I do feel like you said, it's covering it up. I think there's a sliver of it that's outside the lens.
Yep.
But probably 80-90% of that is under the lens completely, rather than like half on, half off like they usually are. Yeah.
And yeah, I agree. So it's not, the edge of the lens is not at the apex of the pinguecula. It's, maybe covering 75% of the pinguecula. So it's just a hint closer to the limbus than what many pinguecula look like. And so when I fit...
Let me go back to the last one for just a second. So yeah, okay. So the mark there at 180, 9 o'clock is pretty close to the apex of the pinguecula. It might be a little below the mark, but that's a really nice reference point, because it'll be easy to determine where to put the microvault, given the fact that it's really close to a hash mark there.
Yeah, if you go back to the white light, let's see if we can see the hash mark. It's a little harder to see. I might have rotated it, counterclockwise.
The dots are still down at 6 o'clock, so it's
so it's very close. I may have rotated it 5 degrees. I may have left it right on the right on the 180, which is nice, because then you can just say 180 meridian nasal, and align that right up. And what I do with my slit lamp is I make a thin parallel pipe beam, and I measure the area of compression, the white spot, and then I add a 0.5 millimeter. That's just sort of my regular algorithm of how I decide how wide to make the lens, or to make the pinguecula. So if it was a 2.5 millimeter blanched area, I would order it at a 3 millimeter microvault diameter, just to make sure we get over top and then have a little room for that microvault to ramp up to its highest depth. And again, this one, I probably put it right on the edge of the lens.
That's a really good point to make, is that in terms of the area, if you go too small, then what's going to happen is you are going to still land on the edge of this bump, and you're going to probably overvault the center of it and undervault the edge of it. And you're not going to align like you could. We want to remember that the bump on the eye probably is more focally elevated than the microvault, which will be more gradually ramping up in depth. And so I agree completely. And the other thing too, is you look at that and you see the area that looks compressed. Again, it's like if you push down on the top of a hill, you're not going to compress the whole hill. At some point, you're going to compact it and you're going to stop pressing. And that's why you have elevation above and below, which really means that you haven't even touched the very edge of the area yet. The bump is you're still vaulting the edge of it in the periphery. Sure. So I agree completely. I think it's a great take home to measure it and then add like a 0.5 to allow for once you don't land on the apex anymore as much, you're going to probably need to land over a wider area. Otherwise, you're going to hit the peripheral part of the bump.
Yeah, and so I would anticipate a nice aligned edge when we, or at least very close. Perhaps the microvault will need a little fine tune, but I didn't make any adjustments to the edge otherwise. I don't want to predict what's going to happen. I want to get that microvault aligned first and then see what's going on, especially with, otherwise everything looks pretty good. So I just wanted to address the microvault alone. And so again, how would you decide what depth to do? Let's say it is a 250 micron measurement on this parallel pipe, so 2.5 to 3 millimeter pinguecula. How would you decide what depth to order?
Well, I think just as you're talking about going a little larger, I think if anything, you want to probably err on going a little deeper, because it's easier when you get reversal to know I have to back off. Mm-hmm. Because if you make this microvault too small or too shallow and you're still landing on it, then you have to fix it again, and you don't know how much more to go necessarily. Whereas if you overdo it and you can see clearly I'm overvaulting it, and you were at, let's say, 300, then pretty much you're going to back down to, let's say, 200. It gives you a pretty good range. Again, my rule of thumb for a pinguecula is about 300, unless I've got data to tell me otherwise. This one's a little bit on the shallower side. So I would say, looking at this, maybe 250 to 300, somewhere in there. But again, I'd rather slightly overvault it than undervault it, just to make sure that I get the area above and below to actually land on the sclera. Then it becomes easier, I think, to fine tune that microvault if you overdo it rather than underdo it.
Yeah, I'm pretty sure I did do 250 on this one. Mm-hmm. So if it's a 2.5 millimeter pinguecula, 250 microns. 3 millimeter pinguecula maybe gets 300 microns. Again, plus or minus a little bit based on each individual pinguecula. Some are definitely more nodular, some are more flat. And you can kind of assess that based on experience. But again, I think 250 to 300 is kind of my go-to as well when I'm not exactly sure where to start in the absence of using, scleroprofilometry or OCT data. Again, in this gentleman, because I didn't really notice the compression there previously, I think this was his first dispense. So during the diagnostic, the pinguecula just really didn't jump out to me under the lens. So again, I don't have profilometry or OCT data, and I'm not going to go, well, I probably have profilometry data. I take that back, but definitely don't have OCT data. And I certainly wouldn't go and measure it after it's been sitting under a lens for a while. So that's the way I would do it. And it's actually, again, like pretty easy. I think this is one of the most impactful changes that we can make to the haptic of a scleral lens, both in comfort and cosmesis for our patients, because they often get pretty red. Mm-hmm. And it's just not that hard. I love that.
Well, and a couple other nice things about this one. If someone's out there is like, well, I've not done a microvault and I'm not really sure. If you could take pictures just like this, these are amazing pictures. If you send these to consultation, they would all literally take it from there for you for the most part. Like they could figure out the size, location, etc., just given these pictures, because it's pretty apparent. The other thing too is that you might say, well, the eye isn't really that red. The patient, what if they're not complaining of fogging and whatnot? And the reality is, though, is if you look at that lens, it is decentering a little bit inferiorly. Mm-hmm. And that's, again, because when you lift off one edge up into the air and it doesn't conform to the shape of the eye, it's obviously going to be more vulnerable for gravity to drop that thing down and pull it inferiorly, because it's got less surface area to hold on to on the nasal side. So it goes back to just more than, cosmesis or maybe a little bit of leakage, fogging. It actually goes back to a whole bunch of things that it affects the fit in so many ways. And even that leakage on the other side, it's entirely possible when you fix this with the microvault on this side, you change the leakage on the other side.
Yeah.
Because it will drop the whole lens down, and it may even bring that the internal landing point on the temporal side down into position with the sclera better. And so you may fix the leakage on the other side too by putting this microvault in. It's just really, it's one, like you said, it's one of the most impactful things you can do to the fit as a general rule, because having that bump there creates a whole lot of havoc.
Yeah, I sure hope it fixes the other fluoresceine seep channel. That would certainly be nice if I didn't have to address that. But even then, if when you look at that blue image or under the cobalt blue, the majority of the fluorescein exchange is happening over the pinguecula, and that other one is more minor. So that may, hopefully that, even if it doesn't totally seal off, it's not something that I need to get too in the thick of it with. And but again, here we just nice, easy adjustment. And if you want to go to the next slide, I just had kind of the, here's what a microvault looks like on the lens. And so it's important to remind your patients that, hey, if you feel the lens edge, it's going to look like there's a little notch or a little bump in the lens, like you didn't break it. Nothing's wrong with it. I intentionally did that to address, XYZ assessment. So again, just remind your patients, especially if it's a moderately sized microvault. And then you can go to the next slide. And this is just the kind of the basic instructions. And so, the depth and the width are what we've already talked about. Those are pretty easy. Measure it with the slit lamp and, just estimate the depth. So we had considered maybe about 3 millimeters by 300 depth, width and depth there. And then the next one is the decentration. So on the images, and this is decentration from the middle. So if you wanted the microvault at the very edge of your lens, then it's half of the diameter. And a lot of the times, if you don't specify it, that's where it would go, because we kind of just assume that the edge of the lens sort of splits the pinguecula. However, if you wanted to get really particular, like with my photo, I could take it in like a 0.5 millimeter. So if this was a 16 millimeter lens, half of that is 8. So I could do maybe 7.5, and then the microvault would move in a little bit and more of the microvault would be under the haptic. So rather than getting kind of a half sphere, we would get, slightly more than that. So the apex of the microvault would be there, and then a small amount of the microvault starting to come down on the other side. I don't believe I did that. I think I decided I'd go from there and see how it's looking. And there are some unique cases. I should have pulled up the one. I have a nice anterior segment OCT over a Salzmann's nodule. I do work in a cornea practice, so most of my patients with Salzmann's nodules are getting them removed. But occasionally I have a patient that's not a good candidate for epithelial removal due to healing concerns, or maybe just fear of surgery. So then I'll actually measure from the center of the lens to the apex of the Salzmann's nodule and put it there. So sometimes my decentration is like a 4 instead of an 8. And that usually takes a few more little tweaks and adjustments to get that lined up just right. But occasionally it's fun to put a microvault completely in the lens. And that's how we would modify it. Where it goes is with that decentration parameter. And then lastly is the axis. The axis is similar to, at least on the Zen lens, the right-hand side is always 0, above is 90, left is 180, and inferior is 270. And so you use that axis of the lens from 0 to 360 to tell them where on the circumference of the lens does this microvault go.
So do you want to, can we go back to your picture and actually do these parameters real quick?
Yep.
So I think this is a good one to use. We can use the white light one too.
I think you can see the hash mark there. It's just a little bit of a light within that fluorescein.
Yeah, just right next to that bright reflection. It's just right below it. Yeah. So, okay. So again, in this case, let's say we were able to take our slit beam and measure the height of that area of compression from top to bottom. And let's just say it was 2.5 millimeters. Yep. So then the diameter of your microvault you'd order would be 3 millimeters.
Correct.
And that's going to then imply that if you were to put that at the edge of the lens, the radius would be 1.5. Okay. But if you're going to move the apex inward, sorry, if you're going to move the apex inward, then that's going to also change the how far it goes into the lens. So in this case, you'd have to consider where do you want the apex to be. And so, as you mentioned already, this is not quite at the edge of the lens. So if this was a 16 millimeter lens, where would you put the apex? So you think like 7.5 or even 7 3/4, or what?
That's what I was thinking, like 7 3/4.
Yep.
if they can do that, if it's not 0.5 millimeter steps, then I would do 7 3/4.
Oh, I'm sure they could. Yeah, you could probably do 7.7 or 7.8
Yep.
or
I
whatever.
think that's what I would do, is 7.7.
Okay, and then axis wise, again, this is pretty much right at 180, although
It
it might
is.
be maybe a couple degrees below, and you could be nitpicky and say, I want it at 183 or whatever you want.
Yep.
You can be real specific with it, and they can decenter it by whatever you want. And then height wise, we kind of already talked about too. This is a pretty shallow pinguecula overall, so starting off maybe around 250 would be a good point. You can always tweak it up or down. Thing to keep in mind, again, we talked about maybe overshooting slightly, but at the same time, if you undershoot it, a lot of times the lens will compress it slightly, and it will actually maybe even fade a little with time and shrink a little with time. And so even if you're bumping it slightly, if you're not quite deep enough, you may be okay with it over time. The biggest thing, again, the conj has a lot of forgiveness. The biggest thing is, do you take care of those areas, those channels of leaking above and below? Do they essentially go away? Because if so, then you probably have enough depth to that microvault.
Yeah, and if I were dispensing a microvault that I'm not sure if I should elevate it or not further, I would let the patient wear it for a few days, have them come back, and then I would take the lens off, stain the eye, and kind of look for that gutter or that, very edge of the lens. I call it a conj gutter, but a gutter from the lens edge digging in. And if I saw it, then I would increase it another 50 microns.
Yeah.
And so you don't necessarily have to decide at the dispense if it's aligned or not, because obviously we know that the lens is going to settle, and it just determines how much, and that where it's valuable to let the patient wear it for a few days and then reassess.
Yep.
So this one here, again, it would be 3 millimeter microvault at a 250 micron depth. Axis, let's call it 183, with a decentration of 7.7 is what I would do.
Yeah.
Recently, actually just yesterday, I was catching up with my resident, and she wanted to add a microvault. And this was a good example, and I wish I had photos for you. The lens is rotated 37 degrees to the left. And the microvault is 15 degrees. It's another left eye. The microvault is 15 degrees below the 180. So it's at axis 195. And the lens is rotated 37 to the left. And so the 180 meridian of the lens is actually kind of above the 180 meridian of the eye. And so then we can talk about, how we described it to the consultant was, hey, we said on the meridian of the eye, the pinguecula is at 195. The lens is 37 to the left. And so then it's actually ends up being 37 to get to the 180 meridian of the eye, and then an additional 15. So it's actually, axis 37 plus 15 is how we got to where we go. So that's 47, 52. So 52 degrees past the 180. So that's 120, did I say
232?
232, excuse me. Yeah, 232.
Yep.
And then so we put it at axis 232 on the lens. And so you can describe it in multiple ways, lens rotation, position of pinguecula under the lens, position of pinguecula on the eye relative to the eye's horizontal meridian. And I think more information is better. A lot of the times I will draw a picture on my lens invoice on like, hey, here's the rotation, here's the pinguecula, here's the size of the pinguecula, here's the difference between everything when I'm measuring rotations. And then I'll describe it in words like we did to the consultant. And I'll also take a picture just to make sure that they agree and they can do their own math to verify where we placed the pinguecula. And those are helpful ways to navigate around that. Again, even just a hand-drawn picture of what we see here is good information for the consultant too.
One other thing I think that is valuable about a microvault too is if you really need it, if there is even if there's a shallow bump on the conj that you can microvault, it adds a lot of stability to the lens rotation. And in the past, we haven't always been that concerned with it. But if you're going to add a front toric, or even now if we're talking about adding HOA optics, stability is really important. And those patients have microvaults that fit properly. That just adds a whole lot more lens stability, because that little microvault is not going to rotate off of that bump as long as it fits it relatively well.
Mm-hmm.
So I think you can, when you're searching for ways to stabilize a lens fit, looking for opportunities to add a microvault can certainly give you more lens stability if you actually need it.
So let's go big here. How do you feel about microvaulting, say, a bleb?
I mean, it depends on the individual patient. I mean, those are the situations I think that you have to not have a rule that applies to everybody. You individualize it. You look at the case in front of you. Part of it is going to be, I think, is what does that bleb look like, right? Like if I've got a real thin walled avascular bleb that hangs over the cornea, I probably don't want to microvault that as much as one that's a little bit more shallow, low lying, thicker walled, maybe, builds off the cornea, its height rather than hanging down over the cornea.
Mm-hmm.
So I think it depends. Like I've got patients who were in sclerals who had blebs done, and it just looked like, yeah, I just don't feel good about trying to vault over this. And we moved them back to a corneal gas perm, and they were fine.
Mm-hmm.
In some ways, actually having that filtering bleb up there, I think helps reduce lens awareness because they've got something that's even thicker above it that the lid keeps the lid off the edge of that contact more. But again, I've got lots of patients in sclerals that have had blebs and have shunts and whatnot. And it really comes down to looking at the bleb, looking at the depth, looking at, just again, how risky does it look if I were to inadvertently fit this poorly, God forbid,
Mm-hmm.
how much risk am I putting the patient in? So I think it individualizes, but I have no trouble doing it given a bleb which looks like it can tolerate it.
Yeah.
If that's a cheap cop-out way to put it, but yeah.
I have the luxury of having the surgeon who does the bleb
Mm-hmm.
right next door. Like I can literally pound on the wall and get his attention. And I've had a couple patients recently where we've done like a posterior tube,
Mm-hmm.
posterior to the iris, and man, is that nice.
Yeah.
The corneas do better. The scleral fit is basically uneventful because the bleb is pretty far back.
Mm-hmm.
I can understand from the surgeon standpoint where it's harder to view the bleb
Yeah.
because it's more posterior, and if there's concerns. I think there's more concerns around being able to view I'm not a surgeon, so maybe I'm just making this up, but on a trab versus a tube,
Mm-hmm.
but again, like tubes, being able, it's less about the bleb and more about the channel that the tube is in, being able to view it, make sure there's no erosion over the tube. So you might still need a microvault over the area of the tube, but that's much more manageable than it's going to be harder to compress a tube versus like messing with the filtration of the bleb.
Yep.
And so if you have the opportunity to discuss, hey, is the scleral lens like essential to the patient's daily well-being for vision and other things? And like, there is no other alternative, maybe a corneal gas perm, but some sort of vision correction with a GP lens is part of the patient's plan. If you can talk them into doing a posterior tube, they just do so good, especially if there's a PK. Once the tube is in there, it changes the flow of the aqueous in the anterior chamber. I feel like all corneas go south after that, and they're much, much more tolerant of a posterior tube. So when we get more disease-based, if I can put a tube in the back, behind the iris versus in front of it, it makes our lives as scleral fitters. And to be honest, I think it makes the patient's life better too. And so we're kind of toying with that a little more often when a scleral lens is involved. And I feel like it's really made a difference. Yeah.
And I think we've got new options in glaucoma surgery. And again, the relationship you have with the glaucoma specialist you're working with helps in that you can discuss this and say, hey, look, if the glaucoma isn't severe, can you do a more minimally invasive procedure? If the glaucoma is more severe, can you consider doing a tube that looks a little different? I mean, there's different ways to approach it. And again, I think you're right. I think communicating and I think the patients appreciate it's just not about your life easier. When you have a patient who's going to need glaucoma surgery and it runs the risk of them not being able to wear their scleral. That's a concern for a lot of patients. And if you can talk to the patient and explain to them, I'm going to talk to your surgeon and I'm going to just let them know how important this lens is to you. And if there's anything they can do about it to allow you to continue to wear it as easily as possible, then we're going to try for that. And I think they'll appreciate the communication then and all sides of it.
Yep. Yeah. So microvault away, people. It's a good thing.
Yeah.
So.
Yeah. And again, microvaults for many years, we only had the option of doing one with a limited size and depth and all that. And now we do have the option of adding a second one, which is great for patients who've got pinguecula on both sides. In the past, we either had to microvault the worst one and leave the other one alone, try to somehow notch it out or what have you. But now we can do two. And on top of that, you can kind of semi-stack them so that if you really need to, if you've got somebody with a lot of surface area on a bleb, you could theoretically put a microvault next to another microvault and give yourself a larger area without necessarily going super, super deep in the center of it. There are a lot of ways now you can approach this. And again, consultation, pictures and consultation are going to be really helpful in the more complicated ones.
Yep. All right. Well, I think that is a great wrap up for today's topic, I guess, and really enjoyed talking about it. It's fun to kind of go back to the basics. I think we believe that the microvault's been around since like 2016. So I think we all kind of believe it's sort of just integrated into how we do things now. But I still think there are people who are toying with getting used to using one and, gaining confidence with it. So I think that was a great cover.
Yeah, it's a very rewarding skill to gain in your scleral lens fitting arsenal, to be able to do that as something that's not that difficult. And you get good at it and you start using it more and more. Again, I think it just makes you feel more confident that you're providing your patient a better fit.
Yeah. So, all right. Well, I'm off to crush it at pickleball. Hopefully my knees make it through.
They will.
I'm not on crutches next time you guys see me.
Right.
But otherwise, have a great weekend all. Good to see you again, Jason.
You too.
Bye.
Thank you.